Hepatocellular carcinoma is one of the leading causes among the deaths, leading to a high mortality rate. Today we'll be talking about the hepatocellular carcinoma. So far we have been discussing about different kinds of the benign tumors which are related to the liver. Today we'll be talking about the hepatocellular carcinoma and some of the metastatic tumors which ultimately are involving the part of the liver. So talking about the hepatocellular carcinoma, it's like a malignant process which is involving and which is extending into the liver parenchyma. Not only the liver parenchyma, but it also involves the hepatic and the portal vein plexus, which is residing somewhere in the vicinity. So if we talk about the demographic, it is more common in the African American population as compared to the Asian population. Plus, if we talk about the important risk factors, then hepatitis C is one of the major risk factor in the pathology of the hepatocellular carcinoma. Why the hepatitis C is important and it's leading? Because obviously as a result of the chronic infection and the chronic inflammation, we all know that actually the patient develops a CLD, which is a chronic liver disease, and it's mostly leading to the cirrhosis of the liver. So the cirrhotic liver has got higher chances of the hepatocellular carcinoma on the background of the malignant process which is already undergoing within the liver. The other causes for the hepatocellular carcinomas are mostly the alcohol abuse, especially chronic alcoholism that can lead to the hepatocellular carcinoma. Some of the autoimmune causes, they can also, like the autoimmune hepatitis, can also lead to the hepatocellular carcinoma. Sometimes the non-alcoholic fatty liver disease on the background of their chronic process, like the chronic inflammatory process leading to the cirrhosis of the liver, it usually leads to the development of the full-blown hepatocellular carcinoma. Now, another important thing to know is like the gender predisposition, or you can say that males are more usually prone to the development of the hepatocellular carcinoma as compared to the female. So you can say that the male to female ratio is 3:1 in terms of the hepatocellular carcinoma. Plus, if we talk about the age decade, then usually 5th and the 6th decades of life are important in the development of the hepatocellular carcinoma. So far, you should know that the hepatocellular carcinoma is a malignant tumor of the liver, and it usually develops in the background of the chronic inflammation and the background of the hepatic hepatitis, or in the background of the hepatic cirrhosis, the chronic liver disease, on the background of the alcohol abuse and the autoimmune hepatic processes which are involved in the liver. Plus, you also should remember the genetic predisposition, like the males has got a higher incidence of development of the hepatocellular carcinoma as compared to the females. Plus, one more thing which becomes important to know is like those conditions like the biliary cirrhosis, and especially the primary biliary cirrhosis, that can be one of the cause leading to the hepatocellular carcinoma. So if we talk about the different forms, or you can say the types of the hepatocellular carcinoma, then it can be a single large mass which is involving a particular portion of the liver, or it can be a multinodular cirrhotic appearance giving to the hepatocellular carcinoma, or it can be a diffuse type. So usually you categorize this into 3 types. One is the multinodular type, the other is a single large mass involving any of the portion of the liver, or the other way, it can be a diffuse type of the cancer. So Usually, we do not know the exact mechanism or the different cause of the development of the hepatocellular carcinoma in the right lobe, but the research and the data actually shows that there is more of the incidence of the hepatocellular carcinoma, and usually it involves the right lobe of the liver more frequently as compared to the left lobe of the liver. So if we talk about the histopathological differentiation, then obviously we divide it in moderately differentiated, poorly differentiated, and the well differentiated carcinomas. Plus, the hallmarks or the signs of the inflammation and the signs of the metastasis and the signs of the malignancy would be there already if we talk about the histopathological findings in case of the hepatocellular carcinomas. So high mitotic figures and increased nuclear to cytoplasmic ratio, and then you can see the nests of the cells within the histopathological findings. Plus, another important thing to know is like the differentiation of single mass enclosing in a liver, or their multinodular parts which are involved in the part of the liver. That also becomes important. So if we talk about the clinical presentation of such patients, usually they present to you with anorexia and weight loss. These are the most important and clinical features. That's how they are presenting to you. But those patients usually do not have a pain, but if there is a kind of a rupture or there's a hemorrhage within the cirrhotic nodule or the malignant nodule in the liver, then it can cause a quite considerable pain, and the patient can actually present to you in acute emergency. Otherwise, the patient will have a dull ache pain. So since we're just talking about the phenomena of the development of the cancer, so it's a good diagrammatic representation. It's going to help you understanding the pathophysiology. So actually what happens is like if there's a healthy liver and then it's a non-alcoholic fatty liver disease, then obviously you can see there would be fatty enlargement of the liver. And then because of this fatty enlargement, there would be non-alcoholic steatohepatitis, or you can say the kind of the inflammation. So if the inflammation goes on and it's a significant fibrosis within the non-alcoholic steatohepatitis, and then sometimes the fibrosis becomes very much extensive and it leads to cirrhosis of the liver, then this cirrhotic liver can actually develop a full-blown hepatocellular carcinoma. So actually it starts from the non-alcoholic fatty liver disease or alcoholic fatty liver disease, because when we talk about the causes behind this, then there is the cirrhosis of the liver, hepatitis C infection, and the other causes are the non-alcoholic fatty liver disease or primary biliary cirrhosis or primary biliary cholangitis. So actually, this was a healthy liver. It developed the alcoholic liver disease or the non-alcoholic fatty liver disease. There will be enlargement of the liver, and that will lead to non-alcoholic steatohepatitis, and it will lead to the inflammation. And this inflammation either would resolve or it will converts into chronic inflammation. And this chronic inflammation either ends up with a fibrosis or it ends up with a cirrhosis. And on the background of the cirrhosis and on the background of the chronic inflammation, there's a tendency to develop in a full-blown hepatocellular carcinoma. So if the patient already has developed this hepatocellular carcinoma, it can be in the background of the non-alcoholic fatty liver disease, or it can be in the background of the alcoholic liver disease, or it can be in the background of the hepatitis C, because what hepatitis C is actually doing to the liver is causing the infection, and infection ultimately leads to inflammation, and this inflammation will end up in a fibrosis and cirrhosis, and then ultimately the cirrhosis would be kind of giving to the development of full-blown hepatocellular carcinomas. Now, the patient actually can present to you with anorexia, with weight loss, or with a kind of aversion from the food, or the patient can have a dull ache pain in the right hypochondrium or the right upper quadrant of the abdomen. And sometimes, if there is a nodular malignant lesion present in the liver and it's kind of a hemorrhage into that particular part, then this can actually lead to the development of the acute presentation of the hepatocellular carcinoma. So the fibrosis and the cirrhosis, that becomes the important cause, and the cancer can be on the background of the cirrhosis, or the cancer can be on the without the cirrhosis. So if we talk about the investigations, there are some very important investigations when you are diagnosing a case of the hepatocellular carcinoma. So usually when you do a routine examination, the liver function tests are deranged. Maybe there is raised in the ALT, or there's a raise in the ALP, but the ALP is more raised as compared to the ALT. And then you also combine it with the alpha-fetoprotein. So alpha-fetoprotein is a kind of a tumor marker in case of the hepatocellular carcinomas. And when there is a right upper quadrant pain, or the patient is giving you a history of anorexia, or the patient is giving you the history of a weight loss, and you're combining it with a deranged LFT, especially the alpha-fetoprotein is also raised, and ALP is also raised, ALT is also deranged, and alpha-fetoprotein is also raised, then that's a kind of giving you a suspicion, or a kind of a probable suspicion about the hepatocellular carcinoma. Now, talking about the investigations, especially that are going to help you differentiate whether which part of the lobe is involved, or it's a kind of a diffuse cancer, or it's a kind of a nodular cancer, then what actually you do is like you do the ultrasonography, or you do the CT scanning. And CT scan is a very, very much sensitive investigation, and it picks up the lesions wherever they are present. And you can also do a MR scan, or you can do a multiphasic CT scan. So the multiphasic or a triphasic, usually in little setups, triphasic CT scan is enough, but sometimes some setups also do the multiphasic ultrasound, multiphasic CT scan. So the multiphasic, how it's going to help you, because the multiphasic will tell you about the arterial status as well, and the venous status as well. Because what happens is, like in hepatocellular carcinoma, there's a tendency that the tumor would be invading, and it would be involving the portal circulation and the hepatic circulation. It would be involving the venous or the arterial bed. So the multiphasic is going to help you diagnose if there is a venous invasion, or is it there any kind of the arterial invasion. So that's how it also becomes important. So combine the invasive investigation or the baseline investigation with the non-invasive investigations, and you combine the liver function test. You send the tumor markers. If alpha-fetoprotein is raised, usually and the background, usually if we talk about the normal value, then it should be alpha-fetoprotein should be less than 20 nanogram per deciliter. This is the normal cutoff value. But in case of the cirrhosis, and on the background of the cirrhosis, and if the alpha-fetoprotein is greater than 200, or still it's equal to or greater than 200 nanogram per deciliter, then it's a kind of a diagnostic value, or a diagnostic limit, which is actually telling you about the malignancy. So combine the liver function test. If the liver function test is deranged and alpha-fetoprotein is very much raised, 200 and maybe more than that, then you'll think about the hepatocellular carcinoma. Then you would be moving towards the imaging techniques or the radiology. And ultrasound can be helpful, but the best thing to do is the triphasic or multiphasic CT scan of the abdomen or CT scan of the liver, because it will be telling you about the arterial or the venous involvement. So if you have already made a diagnosis of a hepatocellular carcinoma, the next thing is to stage the tumor. So the staging can be TNM staging, or it can be American Liver Association staging, but usually we do the staging depending upon the TNM staging. So if the stage is like T1 to T4 with no metastasis, no nodal metastasis, or no distant metastasis, then usually the stage can be stage 1, 2, 3, A or 3B. But if there's a nodal metastasis, whatever the stage, whatever the T stage is, but there is a nodal metastasis, that means there is an N1, whatever the T may be 1, 2, 3, 4, whatever it is. So if there is a nodal metastasis, then it is a stage 3C tumor. And the distant metastasis would be obviously a stage 4 tumor. So stage 0 is probably, the stage which is a kind of a very early stage, and there can be a single nodule or a single part of the liver which is being involved, and the tumor is less than 2 centimeter, and you can say it's a kind of a carcinoma in situ. So if it is a single tumor, it can cause a portal pressure, and the portal pressure can ultimately lead to the slices of the bilirubin. But usually, in case of the single tumors, the other compensatory processes, they limitize the normal pressure and the pressure of the bilirubin. So bilirubin and the pressure remains normal, and in case of the local tumors, the option you have is a resection. Okay, so the ideal thing in case of the limited tumors or stage 0 tumors, which is carcinoma in situ, and they are usually single or they're less than 2 centimeter, you can go for resection. Now stage A to C tumors, like you can say stage 2 or 3 tumors, you categorize them. It's an early stage A tumor, it's an intermediate tumor, or the advanced tumor. So in case of the early stage tumors, they are single or they're nodular, but the nodules are 3 or less than 3, and per nodule the size is less than or equal to 3 centimeter. Then what you do, that you can go for some kind of a local resection, and you can see if there's a kind of associated diseases, and then you can go for the radio frequency ablation in case of such diseases. Now if you talk about the intermediate, but before moving to the intermediate one, let me tell you that in case of the very early stage tumor or early stage A tumors, there is a kind of a curative treatment. Either you go for the radiofrequency ablation or you go for the local resection of the tumor. The conservative treatment can, most of the time, people offer the conservative treatment as well, but if you do the local resection or you do the radiofrequency ablation, the curative rate is like 30 to 40%, and the median survival with this rate is a 5-year survival rate. So in case of the intermediate B, you go for transarterial chemotherapeutic embolization. It's like you're going you're inserting a catheter into the artery, and then you do the chemotherapeutic embolization. It can be one of the effective kind of a treatment in case of the hepatocellular carcinoma, especially because in case of the intermediate type B tumors, they have already been invaded into the vasculature. So you go through the arterial line, or you insert a catheter into that, and then obviously you do the arterial chemotherapeutic embolization, and target is like to achieve a cure rate of 20%. And with this, if we talk about the mean survival rate, and it can extend up to 2 years. In case of the advanced tumors in which there's a nodal stasis, or there's a portal invasion, or there's a distant metastasis as well, especially you can say kind of the type 4 tumors or stage 4 tumors, then you put the patient on a chemotherapy. And if we talk about the chemotherapeutic agent, sorafenib is one of the important chemotherapeutic agent which is being used, and the target is like to give a curative rate of 40%. And if we talk about the mean survival, so the mean survival rate with this is 11 months, or you can say ranging a year or a half a year. If we talk about the stage D tumors, which have already been metastasized to the different sites, then you can only give the best supportive care. Like if there are, vascular invasion or metastasis to the lungs, or metastasis to the intestine, then what happens is like you need to give a good best supportive care. So if we follow the TNM staging for the hepatocellular carcinoma, then always remember that you classify these tumors if there is a tumor invasion starting from T1 to T4, whatever it is, with no nodal metastasis and no distant metastasis, then usually they are categorized in stage 1, 2, 3A and 3B, and the 3C tumors, they have got a nodal metastasis, and stage 4 tumors, they have got a distant metastasis. So on the basis of their metastasis or their involvement, or if there's a carcinoma in situ, so if we talk about stage 0 tumors, that means they are single tumors and the size is less than 2 centimeters, and they are very much confined, and you can go for a local resection. And if we do a good local resection, the curative rate is 30 to 40%, with a mean year survival rate of 5 years. And if we talk about the early stage A tumors, so in case of the early stage A tumors, the size can be somewhere ranging equal to or less than 3 centimeter, and usually they can be single nodule, or there can be 3 nodules. So you go for the radio frequency ablation or microwave ablation. So in case of the intermediate B tumors, in which you suspect a kind of invasion, then you go for the transarterial chemotherapeutic embolization, which is becoming famous day by day. And in case of the advanced tumors, which has got a portal invasion or a nodal status or M1 metastasis, then you go for the good chemotherapeutic effect, and the mean survival rate is 1 year to 1.5 years. And for the tumors which have got extensive metastasis, then obviously you need to put them on a good supportive care, and the only thing is like to relieve their symptoms, because mostly the hepatocellular carcinomas, the patient usually present to you with massive ascites, and what you can do is like giving them a comfort, or draining the ascites, or doing the ascitic tap, or you do the you do the synthesis. Okay, so the other thing is like you can also kind of, if there's a pleural effusion, metastasis to the lungs, you can intubate the patient, or a chest intubation can be done. So providing a good palliative or supportive care, combining with the chemotherapy, but usually in the advanced stages in which there is a distant metastasis, and there are lung metastasis as well. So then you don't start the chemotherapy because it becomes unresponsive, and mean year survival is very much less, as ranging between 3 to 6 months. So now talking about some oncological contraindications, the contraindications to the chemotherapy, and contraindication to the surgical resection. So if there's extrahepatic metastasis, if you are thinking about resecting a tumor within the lobe of the liver. But if there's extrahepatic metastasis, then obviously it's not going to help. So in case of the extrahepatic metastasis, you don't go for the local surgical resection. Or if there are multiple and bilobar tumors, then you don't go for the surgical resection. Another contraindication, if there's involvement of the main bile duct, you don't go for the surgical resection. Or if there's a presence of tumor or thrombus in the main portal vein, then you don't go for the surgical resection. So always keep in mind, surgical resections are going to help the patient in case of the diseases in which the size is small and there's no nodule and the distant metastasis, or there's a single tumor or a single nodule which is involving the liver. So keep remembering the contraindication to the surgical resection, the extrahepatic metastasis, involvement of the bile duct, involvement of the main portal vein, or there is a multiple and bipolar tumor, then you are contraindicated and you do not proceed for the surgery. Now, another important thing is with the hepatocellular carcinoma is a preoperative evaluation for such patients. So how do you do the preoperative evaluation? You need to stage the tumor. This is very, very much important, because your treatment, your resection, or putting the patient on a kind of a radiofrequency ablation or microwave ablation or cryoablation, that depends upon the stage of the tumor. So that's very much important to diagnose the patient, to stage the patient, and to grade the patient. So staging, you need to go for the positron emission scan as well, or you can go for the chest x-ray or the HRCT. If there's a consolidation and the patient becomes symptomatic, then you go for all these things. Then patient's fitness is somehow very, very much important, because in the later stages, the patient also develop in calf, and in case of because there's a hepatic dysfunction, then the bilirubin is very much raised, and there is ALT derangement with the ALT, derangement with the ALP, and plus the clotting profile also is very, very much deranged. So correcting that, or transfusing with a good amount of the blood, and transfusing with a fresh frozen plasma, or giving vitamin K precipitates, that actually help for making the patient fit for surgery. And then you need to actually, you need to evaluate if the hepatocellular carcinoma is because of the cirrhotic process. So if there is a cirrhotic process, it's usually a diffuse process, and it involves almost whole of the liver. So if you do the hepatocellular resection, or there's a metastasis as well, so your treatment depends upon these things. And then you go for the CTP scoring as well. So always remember that their survival rate also depends upon the stage of the tumor. So if you early stage tumor, or the stage 0 carcinoma inside, or early stage A tumors, even intermediate B tumors, they have a good survival rate, and it ranges somewhere between 2.5 to 5 years. But those tumors which has already been invaded, or they are metastasized in the lungs or anywhere in the abdominal cavity, then obviously these tumors becomes inoperable, and surgical resection is not the option. So if a tumor size is less than 2 centimeters, it's a single, and you are expecting that the cancer is not developing in the background of the cirrhosis, it's without cirrhosis, then you can proceed for such things. Then another important thing is a preoperative imaging. So preoperative imaging, it becomes important when you're actually staging the patient, or you go for the ultrasound, you go for the CT scan, and then you go for the CT scan of the chest, CT scan of the abdomen. You look for any kind of the metastasis, you check for the status. If there is a status to the, there is bone scans, you also do the bone scans as well. So that preoperative imaging becomes very, very much important. Plus, Another important thing, which becomes important in case of the hepatocellular carcinoma, is the portal vein or the hepatic artery or the main bile duct invasion. So they become a contraindication to such things. Let me tell you another important thing, that in case of the hepatocellular carcinoma, venous involvement is much more common as compared to the arterial involvement. Plus, if you are ordering a multiphasic CT scan, then there would be more of the enhancement of the arterial. If there is arterial portion involvement, then there would be more enhancement in the arterial tree as compared to the venous tree. So talking about the surgical resection, you need to make a diagnosis of the hepatocellular carcinoma. Then you need to choose if you are resecting the tumor, or if it's a single tumor, then obviously you go for the local resection. But in case of the extensive disease and there's no nodal metastasis, no vascular invasion, no lymphatic invasion, no nodal invasion, then you go for the whole of the resection of the tumor. Then you also think about the transplant option you have available in your vicinity, or in the environment, or in a setup you're working. So you have made the hepatocellular carcinoma diagnosis, then you have to go for the treatment option. If he is a candidate for ablation, or he's a candidate for resection and transplantation. So how do you actually do that? You do, if there's a single lesion and the scoring is or it's a kind of an early stage A tumor, and it's a non-cirrhotic tumor, there's a no metastasis, then you go for the resection, or you go for the radiofrequency ablation. So local resection or radiofrequency ablation. Now the transplant candidate, now you go for the orthotopic liver transplantation. It's like you are taking off the whole of the diseased liver and you have another liver, and you go for the transplantation. So if there's a no gross vascular invasion and it's a ABR stage C tumor, and alpha fetoprotein is less than 1,000 nanogram per ml, and there are 3 lesions, all less than 3 centimeter, or there's a 1 lesion less than 5 centimeter, then you do the transplant evaluation. And you choose that such a tumor obviously is not resectable, is not locally resectable, then you go for the orthotopic liver transplantation. So there is a proper criteria for a liver donor, and you do the preliminary testing and the matching, and you find a suitable donor for that. And then there is another important, is a cadaver donor. So you find a suitable donor, or you find a cadaver donor, and it depends upon what is the condition of your patient. And if you have a cadaver donor waitlist, then what you do is like put the patient on neoadjuvant bridge therapy, go for the radiofrequency ablation, go for the transarterial chemotherapeutic embolization. Okay, so you can also go for that. So make sure if there's an ablation candidate, or if the patient is a transplant candidate. And then you have to decide if he's not suitable for surgery at all, then you go for the medical evaluation, or then you also check for if you need to give a best supportive or a palliative care to that patient. So mainly we have divided the surgical principles into 3 categories. If the patient is a candidate for ablation, if the patient is candidate for orthotopic liver transplantation, or the candidate is not suitable, not fit for any kind of a surgery. And in ablation candidate, if there's no metastasis and there's a single lesion and the size is usually less than 2 centimeters, and there's a non-cirrhotic, then you go for the resection, local resection, or a radiofrequency ablation. And in case of the transplant candidate, you do the transplant evaluation. If the lesions are 3, but the lesions are smaller than 3 centimeter, or there's a larger one lesion, but it's less than 5 centimeter, and the alpha lipoprotein is somewhere ranging less than 1,000 nanogram per ml, and or either you have classified in a stage A, stage B, or stage C tumor, and there's no gross vascular invasion. So if you have a suitable donor available, go for the orthotopic transplantation. Or if you don't have a suitable donor, and then you have to wait till the donor is being arranged, or you have a cadaver donor available, then what you do is you put the patient on a neoadjuvant therapy, or you at least give a radiofrequency ablation, or you try to give the arterial catheterization or arterial embolization chemotherapeutic, and then you go for the transplant. And in case of the non-suitable options, like surgery especially, their comorbid factors and their fold lesions and they're multinodular on the background of the cirrhosis, and there is a vascular invasion or lymph nodal, or there's a metastasis, then you go for the radiofrequency ablation, or you go for the microwave ablation, or if the size of the lesion is less than 5 centimeter, or you classify regard then in a stage A or B, then you go for radiofrequency or microwave ablation. And in case of the multifocal disease and it's greater than 5 centimeter, then you go for the, obviously it's a kind of the arterial involvement. So you go for the transarterial chemotherapeutic embolization. And you see if there's a tumor progression, and you see if there's a downstaging of the tumor. So if there is a tumor progression, then you go for the chemotherapy, and most of the time the sorafenib is a good chemotherapeutic agent, and sometimes you also try give a kind of a clinical trials to the new chemotherapeutic agents, or you combine chemotherapy with the palliative treatment, treat the ascites, give a kind of a good supportive care to the patient. So make a proper diagnosis, reach to the cause, either it's a non-cirrhotic hepatocellular carcinoma, or it's developing on the background of the cirrhosis. So always categorize that. Then stage the tumor, which is very, very much important. And then you decide if the candidate is ready, or a candidate for ablation or local resection, or if a candidate for transplant, which is called the orthotopic transplant, or you go for the kind of a view that the patient is not suitable for surgery, then you do the radiofrequency ablation or microwave ablation, or you give a good palliative care to that patient. Then mostly in case of the hepatocellular carcinoma, the reassurance of the patient is very, very much important, and you need to counsel the patient that there is no other option available with us, no surgical option in case of the liver, other than the liver transplantation. Now, there's some criteria for the liver transplantation. Obviously, you cannot transplant such patients who has got the hepatocellular carcinoma, plus there is a nodal involvement, or there's a distant metastasis, or there is gross vascular invasion. Portal vein is involved, the common bile duct is involved, then you don't go for the liver transplantation. You actually don't go for the orthotopic liver transplantation. So you need to guide the patient, and you need to find a suitable patient again and again. You need to do the transplant evaluation. You look for the vascular invasion, and you look for the distant metastasis as well. Now, talking about the metastasis, which is actually coming to the liver, we have been discussing so far about the tumor of the liver, usually which is arising from the liver, it's hepatocellular carcinoma. But there are multiple tumors which are metastasizing into the liver, and among all these, the colorectal cancers, they are very, very much important because they actually metastasize. So you need to define if you are planning to go for resectability, or you're planning for a local resection or radiofrequency ablation to the liver. Even in case of the metastasis, you need to be sure that the parent tumor has been resected completely, or there is no focus anywhere in the body relating to the parent tumor or the primary tumor. But before that, you should know the route by which there is a metastasis into the liver. So actually, this hepatocellular carcinoma disseminates systemically via the hepatic vein, which is a kind of common portal vein metastasis, and it's somehow related to the liver as well. So the colorectal carcinomas, which are involving, we all know that the whole of the GIT circulation is coming to the portal vein, and through this portal vein, it goes to the inferior vena cava. So if there is a metastatic process going within the colorectal part, then through the GI circulation, it comes into the portal vein and it then goes into the liver. So remember this pathway, colorectal carcinoma always disseminates toward the portal vein, and it then comes to the metastasis to the liver. Then some of the pancreatic cancers, they also develop this kind of a portal vein metastasis, and ultimately leading to the liver metastasis. And small bowel carcinomas, they also disseminate via the portal vein, and ultimately, because the portal vein is crossing the liver, and it's actually involving most of the venous sinusides, and ultimately it leads to the liver metastasis. Some other important organs which are the cause of a liver metastasis are colorectal cancer, the pancreatic cancer, and the small bowel cancer, and obviously the cause remains the same. The root remains the same, if that is like the portal vein. Now, another important thing to know is, like, you need to define the resectability. Again and again, I'm emphasizing, but you need to know how actually these micro and the macro metastasis happens. So the metastatic cell, or you can say it's a kind of a malignant cell, it leads to the clonal expansion, and it actually leads to the process of angiogenesis, and the metastatic subclones are formed. And these metastatic subclones then actually lead to the breach of the basement membrane. And then this breach obviously leads to the passage to the basement membrane, and obviously it involves to the transport to the blood circulation. And if we talk about the process, you need to know that there is a malignant cell, and it leads to the clonal expansion, and it leads to the growth in angiogenesis, and ultimately these things lead to the subclonal metastatic formations, and they breach the basement membrane, they get into the circulation, and through the circulation they get adhere to the other basement membrane of the organ, and then there is a dormant micrometastasis or a metastasis formation. But before that, if you are treating a case of a colorectal liver metastasis coming from the colorectal cancer, then you need to stage, and you need to see if there is a chance for a resection or not, especially if the parent or a primary tumor is being cured, or there is the whole of the bowel resection, and you're very confident about the margins, that the margins are clear, and there is no focus of malignant cells anywhere in the body, then you can go for the local resection of the liver as well. And obviously you need to do the preoperative evaluation, and you need to go for the HRCT and CT scan abdomen to locate any malignant cells which are present in the body. Then if the tumor is inoperable, like the colorectal cancers, if they're inoperable, and you know there's a distant metastasis somewhere in the lungs or somewhere in the body cavity, then you go for the chemotherapy for the colorectal cancers. And the chemotherapy is usually 5-fluorouracil, folinic acid, and oxaliplatin. Oxaliplatin is, if you combine oxaliplatin with 5-fluorouracil. It gives a good effect or a good downstaging of the tumor in case you're using the chemotherapy. And the monoclonal antibodies, they can be very, very much helpful in case of the chemotherapy for the non-operable cancers or non-resectable cancers. So we have been discussing about the hepatocellular carcinoma, and we have been discussing about the different kind of metastasis which is involving the liver, and we have been discussing about the treatment options, the frequency ablations and local resections, and the orthotopic liver transplantation in today's lecture. Thank you for watching sqadia.com.